My name is Sam Saha. I am a general internist at the Portland VA Medical Center and the Oregon Health and Science University, and I also serve as chairman of the Oregon Health Services Commission. I recently published a paper on the use of comparative effectiveness research in the New England Journal of Medicine. One of the major problems with implementing comparative effectiveness research is that once you start saying that coverage policy and payment policy should be based on delivering the most effective and most cost-effective care, people start talking about what we call the R word, rationing. People say that you're basically going to be rationing health care. And there are a lot of concerns about rationing, and it raises a lot of sort of negative images. But honestly, rationing is simply delivering health care where it's needed. Right now in the U.S., there's really very little incentive for people to get what they need, to get just what they need and not more. People in general get a lot more than they need. Some people who have health insurance. The other people who don't have health insurance get essentially nothing. They have no coverage whatsoever. So we have this system where a lot of people get more than they need and a lot of people get a lot less than they need. And rationing simply means balancing that equation so that people get what they need. To try to implement a system where people get what they need, Oregon in the late 80s and early 90s developed a plan where they said we're going to explicitly limit the kind of care that people get so that people get what they need. And we don't have a lot of people who are uninsured and a lot of people who are insured. Basically what Oregon said was we're going to prioritize care. We're going to make a list. We're going to rank order healthcare services on a list, and we're going to pay for what we can afford. And when money runs short, we are going to limit what's covered rather than limit the number of people that are covered. And it made sense, but still people had significant problems with it. Now, the kinds of things that we started out limiting were things that, really there was very little evidence for. So surgical treatments for mechanical low back pain, therapies for conditions that would resolve on their own, therapy for minor conditions that really didn't need medical care. It was a lot of minor stuff that we started out limiting, and then over time, basically as the cost of healthcare rose, we started limiting more. So one example is that we had, at a fairly low level of priority, we had the condition of fluid in the ear among children. And there have been lots of studies to suggest that, when kids have fluid in their ear, if they don't have any hearing loss, that really there's not much utility in doing treatments for that. And so that was a service that we had at a low priority. As money ran short, we asked for permission to raise the bar so that we would cover fewer services and that would allow us to cover as many people as possible. It turns out that the federal government had to give us permission to limit services, and one of the services where they said we're going to draw the line was fluid on the ear for children. And at that point, the Oregon process really got stuck because we weren't allowed to raise our line. We weren't allowed to limit the services we covered anymore because the federal government was uncomfortable with it. And what happened basically was then we started losing people. More people fell off of our rolls, and we went back to the sort of healthcare as usual, where we limited the amount of dollars we spent based on the number of people, not the number of services. Okay, so where the Oregon Health Plan sits now is that we still have a list of prioritized services. What's covered is determined by that list, but for many years we have not been able to raise the line on that list. We have not been able to limit the number of services we've covered, and so we've essentially ended up limiting the number of people we cover. So where at the inception of the Oregon Health Plan, we covered about 100 to 125,000 extra people that wouldn't have otherwise been covered. Now we're down to about 20 or 25,000. We've really had to limit the number of people we cover rather than the number of services because the cost of care has risen and revenues have not. Well, I think that, the Oregon approach is just one small piece of the puzzle, but let me just stick with our approach. What I think has to be done, and if comparative effectiveness research is going to deliver on its promise, what has to be done is that we have to allow people to use comparative effectiveness research to really guide the care that is used. If we just put it on the shelf and allow doctors and patients to use it when needed or use it at their own will, we're not going to get very far because again, patients have very little incentive to limit the number of services they consume, and doctors have very little incentive to limit the number of services that they deliver. So if we're going to have comparative effectiveness research really make a difference in healthcare, we have to give it teeth. That means we have to allow people to set coverage policy by it. We have to allow people to set payment policies to physicians so that we can pay physicians appropriately to provide the care that's most effective and most cost effective. And we have to give patients, we have to put some skin in the game for patients so that patients, if they want the care that's less proven, less effective, they might have to pay a little bit more for it. Now, to do that, we have to create a group of people who's going to basically make those decisions. And in Oregon, what we've done is created a group of people that I think addresses a lot of the concerns that many people have had about groups that make coverage decisions. So people have a lot of concerns with insurance executives and government bureaucrats making coverage decisions because they see those people as really not concerned with patient care, but more concerned with the bottom line. Here in Oregon, we have a volunteer group of physicians and consumer representatives who are making those decisions. There's a lot of concern that groups that make those decisions will, be biased against the elderly or the disabled or people whose lives they devalue. And here in Oregon, we've addressed that concern by having people who represent the disabled and the elderly on our group, helping us make coverage decisions. And then there's this concern that a group of people who are distanced from the doctor-patient interaction can't really know all of the different facets of what's going on with that patient and what the right care for that patient is, and that if we don't allow for individualized care, we're really going to hamper the ability of doctors to treat patients in an effective manner. And in Oregon, we've paid a lot of attention to that and tried to sort of stay out of the doctor-patient interaction. We set sort of 30,000-foot policy, but we allow a lot of freedom on the ground level so that doctors and patients can make the best decisions for themselves.